Hello. I'm going to just give you a little bit of information about GU and GYN surgery so that when you observe these procedures at your second clinical, you'll hopefully be a little more comfortable with them. So first, what is genitourinary and gynecologic surgery? We call it GU-GYN surgery. GU surgery is basically any surgery of the urinary tract system, and GYN surgery surgeries of the female reproductive system. So this often includes anything from cystos, kidney stone extractions, prostate surgeries. For GU, GYN would be any hysterectomies, any sort of dilation and curettage or DNC, anything like that. We do have a few pieces of specialized equipment that we use for these procedures. So first, we always use a cysto bed or a cysto table. I know maybe on our tour you walked by OR9, and OR9 we refer to as our cysto room. It has a bed similar to that bed on the left, and it's integrated into the room. We never move it. It has radiology equipment so that when surgeons are doing kidney stone extractions or they need to see imaging inside the patient, it's all integrated into the bed. So it's very easy and nice and just flows really great in that room. We also do have a portable cysto table. So similar to that bed on the right, has the same kind of function. You have to add the stirrups that the patient's leg will go into it, but it can move from room to room. So if there are multiple cystoscopy procedures being done, or for whatever reason room 9 is out of service, we can perform these procedures in other rooms. As I mentioned, the stirrups are very important. So on the far left, we have these hydraulic stirrups. You put the patient's legs in them, make sure they're nice and secure. We do have foam padding if you would need that. One important thing about the stirrups is you always want to make sure that we're raising and lowering them at the same time to prevent any strain or tension on the patient, to prevent causing damage to the arteries, to the nerves in the patient's legs. And then we want to make sure when we take the patient out of stirrups that we are doing so very carefully. The typical procedure is to lower the stirrups on both sides and then pull the patient's legs out of the lithotomy position. Doing it slowly and in small increments like this will help with hypotension. As you can imagine, there's not as much blood in the legs when they're up in the air, and so then when you throw the legs down really quick, all the blood shifts there and can cause a dramatic decrease in blood pressure or hypotension, and can make the patient very uncomfortable and can cause their vital signs to kind of act funny for a minute. So we just want to make sure we're thinking of the implications of positioning when we're performing positioning on the patient. This next machine is a uterine suction machine. So this would be used for a suction DNC. We perform a suction DNC anytime that there is retained products of conception. So if a patient has a miscarriage, or occasionally there will be a delivery with like a retained placenta that we would need to go in and take out for the patient. And for that procedure, this is just like a really powerful suction, but it's gentle enough to not hurt the inside of a patient's uterus. So you can go in and get out anything that doesn't belong. This two pieces of equipment right here. On our left, we have our Fluent or MyoSure machine, which provides liquid distension of the uterus. So they use this for diagnostic and operative. It's called a hysteroscopy. So they're going in to look inside the uterus. And this machine can monitor a volume difference between irrigation fluids, which is very important. You want to monitor how much fluid you're putting in and how much fluid you're getting out. And this machine will monitor all that for you. If we are using the MyoSure portion of this handpiece, it's basically to do like an ablation of the inside of the uterus, or to take any sort of sampling. There will always be a specimen left over that we will need to send, which is why there's that big yellow warning on top that says specimen and sock. And you'll see there's like a little, it looks like a tiny little sock that'll be inside of a specimen container that will collect any specimens that would come out. So any uterine tissue. The piece of equipment on the right is a bipolar generator, which we've talked about cautery before, and bipolar. Occasionally they will need to use this inside the patient. So this is the bipolar generator for GU. So I do have a little video here kind of how the MyoSure works. So I wanted to play this for you. So it will just go in. It can ablate any abnormal tissue, kind of take it out. Basically how it works. Super simple. So positioning for most of these cases is lithotomy. Like I said, there are different degrees of lithotomy. So you can be in very low lithotomy, standard lithotomy, a hemilithotomy where one leg is up, one leg is down, which is not ideal for the patient. There's high lithotomy. And then as you can see in the very bottom, there's a very exaggerated lithotomy. When you're putting a patient in this position, you want to make sure you're looking at pressure points. You're maintaining the privacy of the patient. You know, we do have a lot of windows and doors in the operating room, so it's very important to keep those shut as much as you can. You know, the patient is very exposed in this position. Circulation is very important. I mentioned the hypotension component earlier, and then any other considerations. So stirrups should obviously be securely fastened to the operating room table. You always want to double check them to make sure they're on there tightly before you place the patient's legs in stirrups. If any slippage occurs, it can actually cause hip dislocation, muscle or nerve injury, bone fractures even. So it's very important to check that those stirrups are in the correct position. Patient should be placed in the lowest lithotomy possible for the procedure, and the legs should be placed at an even height. You are also supposed to check the legs periodically to make sure they still have their pulses and still have good skin color, and make sure that you haven't secured them in there too tight and you are cutting off circulation. Risks of the lithotomy position include the hypotension when the legs are removed and even compartment syndrome from having the legs in there too tightly. So as you can see, it's just kind of showing you the correct position here. Nerves you want to watch out for. The femoral nerve and the perineal nerve can be injured very easily in this position if you don't maintain good body positioning. And then as you can see, there's a correct and incorrect at the bottom, and the correct is where the buttocks is closer to the edge of the table. The incorrect one on the right shows that giant gap between the edge of the table and the buttocks of the patient. So you want the very bottom part of their buttocks right at the break in the table. In this position, arms should always be placed on arm boards or tucked. If they are tucked, you want to use caution when raising and lowering the table so that their fingers don't get caught in anything. So common procedures that we perform in GYN surgery are the dilation and curettage, or D&C, a cystoscopy, hysterectomy, nephrectomy, and prostatectomies. So D&C, I kind of mentioned it earlier. This little picture to the right is just a common D&C tray. These are instruments that you would see in a standard D&C set. Basically what they're doing in this procedure is dilating the cervix and removing any tissue from inside the uterus. They can do this to take endometrial samples. They can do this, like I mentioned, for pregnancy loss or spontaneous abortion is sometimes what they call it. A postpartum retained placenta. It can be diagnostic for uterine bleeding or endometrial cancer, and they also frequently will take cervical, vaginal, or uterine biopsies in these procedures and send them as specimens to determine maybe some disease processes in the patients. So a patient is placed in lithotomy position. The vagina and perineum are prepped. They usually insert a weighted speculum and a retractor to expose the cervix. They have an instrument called a tenaculum forceps that they grasp the cervix with. They then dilate the cervix until they have a proper opening. Then they can obtain samples, evaluated for any postoperative bleeding. We remove the patient from stirrups and place a perineal pad on the patient. For these patients, they usually go home the same day. It's usually an outpatient surgery, depending on their other disease processes. Obviously, if they had a baby just recently and they, are having postpartum bleeding and we needed to take out some placenta that remained in the uterus, then they would obviously stay for that. But if they're doing a diagnostic or a sampling, they would go home the same day. You do need to monitor the patient for heavy bleeding, fever, or any cramping for more than 2 days. Slight cramping and slight bleeding can be normal for the first few days. And then patients should refrain from putting anything inside their vagina, so no tampons, no intercourse until they have a follow-up appointment with their doctor. Complications from a D&C can include bleeding, perforation of their uterus, which is why sometimes you will see surgeons will perform a D&C if they're doing maybe something a little more complicated under like an ultrasound. So we will have an ultrasound tech come in and perform an ultrasound while they're doing the surgery, just so that they can see where they are in the uterus and make sure that they're removing all the tissue. Infection is also a complication, and any scarring of the uterine wall. The next procedure we're going to talk about is a cystoscopy, and this is basically just examining the lower urinary tract. They use this special cystoscope that they can go in. We have flexible and rigid cystoscopes. It's mainly just a diagnostic tool to kind of go in, see what's going on. They can put these cystoscopes up the urethra into the bladder. You can see the male prostate. They have ureteroscopes that will go up further so that they can look into the patient's ureters to see any problems with their kidneys as well. So indications for a cystoscopy would be anytime they have blood in their urine, a patient's reporting urinary retention with unknown causes. They have frequent persistent urinary tract infections or cystitis, so any infections in their bladder, any tumors, and even urinary incontinence. So as you can see in these pictures, this first set of pictures on the left, this patient has a kidney stone. So they are going in, it's blocking most of the ureter. So they're going in, breaking it up, and then they're using a little extraction device, which we call a stone basket, to pull that kidney stone out. On the right, you can see what it would look like if the patient had a little tumor in their bladder, and we can remove that as well. The patient is placed in a lithotomy position for this procedure, and then their perineum is prepped. The cystoscope will be lubricated with a jelly, and then it will be inserted into the urethra. The scope is connected to an irrigation and light source so the surgeon can see inside what they're doing. They will take biopsies or perform additional procedures such as a ureteroscopy, retrograde pyelograms, dealing with kidney stones, whatever they need to do. The cystoscope is removed. The patient is removed from lithotomy. Postoperative care for these patients, they usually go home the same day, and once again, depends on their status and any additional procedures. There are no special restrictions. Patients might note blood-tinged pee or slight burning sensation for a few days. Complications can include infection, bleeding, and that minimal pain for a few days. The next surgery we're going to talk about is a hysterectomy. So this would be removal of the uterus. There are different types of hysterectomy. So we can have a total hysterectomy where the uterus and the cervix are removed. We have a total hysterectomy with a salpingo-oophorectomy, which would be removing the tubes and ovaries. And then a radical hysterectomy will remove uterus, cervix, tubes, ovaries, and actually the top portion of the vagina. So this can be done through an abdominal hysterectomy. We call that a TAH, where they will make an incision in the abdomen to remove the uterus. We can also do it as a vaginal hysterectomy, which they will put usually like laparoscopic ports in, and then they will remove the uterus and the cervix out through the vagina as opposed to out through the abdomen. Like I said, this can be done laparoscopically, robotically, or open. So indications for a hysterectomy would include pelvic inflammatory disease, a patient with endometriosis, fibroids, any bleeding in postmenopausal women that has, no cause or cannot be stopped, adenomyosis, or any cancer, or occasionally it can be done prophylactically if patients have genes that they know are going to cause cancer in the future, they have a long family history of cancer. So a procedure for a total abdominal hysterectomy would be the patient is usually placed in low lithotomy. They can even be supine, depends on surgeon preferences. There's still a vaginal prep and an abdominal prep. A patient will usually get a Foley catheter for their surgery, and then we open the abdomen up. This is a lot of procedure here. I kind of put this here just for your general understanding of it, but basically we will go in, clamp and ligate all the ligaments, separate everything kind of away. We clamp incise and tie the fallopian tubes. We will pull the uterus forward, divide all the vessels, the ligaments, make sure the bladder is separated, make sure the bladder is still intact and that we haven't caused any damage to it. Then if we will incise the vaginal vault, close the cervix, remove the uterus. They sew everything shut, so we'll sew the vaginal vault shut, close all the layers, close the peritoneum, and apply an abdominal dressing. For an abdominal hysterectomy, they can go home the same day of surgery or the day after. It's surgeon specific. Most often, patients will stay overnight. They will monitor discharge for the patient. They can have moderate discharge for several days. And then it is an abdominal surgery, so no lifting over 20 pounds or anything in the vagina. So no tampons, no intercourse for 6 to 8 weeks. Things you want to watch for in an abdominal hysterectomy would be infection, hemorrhage, any sort of blood clots, pulmonary embolism, any damage to the GU-GI tract. They are in there working very close to the colon, very close to the bladder, and nerve injuries. Next surgery I want to talk a little bit about is a nephrectomy. So this is the removal of a kidney. They have a partial or a radical nephrectomy. A partial would be when the surgeon removes the diseased part of the kidney, and a radical would be the surgeon removing the entire kidney, usually a section of the ureter, the adrenal gland, some fascia, and lymph nodes. So they remove a great deal more when they're doing a radical nephrectomy. This can be done open, laparoscopic, or robotic. Most of the time in North Kansas City, we are doing these robotically. Indications with this would be any congenital obstructions, any tumors in the kidneys, a severe trauma to the kidney, infections, abscesses, and sometimes even in the case of severe hypertension, they will remove the patient's kidney. So a patient is placed in a modified lateral decubitus position, as you can kind of see pictured here. Then they will put this little piece on the bed, a kidney rest under the iliac crest, which will flex the patient up a little bit, just so that where their kidney is at the highest point. And we will perform surgical antisepsis, back and abdomen from nipple to hip. So they have a very wide range of prep just because that surgical site is a little bit bigger. So they will incise the skin just above the kidney, expose all those muscles. Occasionally they will need to resect ribs depending on where the kidney is. That's uncommon, but it is a potential. They will divide and ligate the ureters. They will ligate the renal artery and the renal vein. Clamp the pedicle of the kidney. Check for any bleeding. Check for any injury to organs that are near. Close the fascia, close the muscle, close the skin, gauze, dressing, and paper tape. For postoperative care for these patients, you do want to monitor their blood pressure, electrolytes, and fluid balance. As you know, the kidney is very important with blood pressure and regulation, electrolyte balance, fluid balance. So, they've lost half of their kidney. Half of their kidney function, basically. They lost a kidney. So we want to really make sure that we're monitoring that. It's a big abdominal surgery. They can't have a lot of pain, so we want to encourage just deep breathing, use of the incentive spirometer. Patients undergoing this procedure usually will stay 1 to 3 days in the hospital, and they will need to avoid any strenuous activity and lifting for 6 weeks. Complications can include infection, pneumonia, blood clots, hemorrhage, and even kidney failure. If the remaining kidney has impaired function, now they're down to 1 bad kidney, so there might be a need for dialysis. So you'll have to watch the patient's remaining kidney function very close. The final surgery I want to talk a little bit about is a prostatectomy. So this is removal of the male prostate. It can be done transurethral, so they will put the cystoscope in through the urethra. They can also do it robotically. Most of the time it's done robotically. There tends to be a better visualization, and it's a much easier, less bloody procedure to do it robotically. Better outcome for the patient, obviously, as well. Indications for removal of the prostate would include a prostate carcinoma or for treatment of BPH. And just a reminder, BPH is benign prostatic hypertrophy, and that's basically the prostate and the surrounding tissue expand. They squeeze the urethra, which thickens the bladder wall. The bladder wall then weakens and loses the ability to fully empty. So removing the prostate allows that urethra to have a better flow. So for this procedure, the patient, if we're doing it transurethral, it will look very similar to that little diagram up top. We place the patient in a lithotomy position, perform surgical scanning and asepsis. They then perform a cystoscopy to assess the prostate, inspect the bladder. Then they insert a resectoscope and a cutting loop. So this will start to kind of cut away the parts of the prostate. So they begin to dissect with cutting and coagulation on a little cautery. It's called a loop cautery, and it just looks like a little loop, and they can kind of cut out and start shaving away the prostate. The bladder is drained to evacuate all the prostatic tissue. They use something called an ilic or a Toomey syringe for manual irrigation. After they feel that they've removed most of the prostate, they look in that area, the prostatic fossa, so the area where the prostate was. Ensure that there's no bleeding and that the coagulation is completed. They remove the scopes, and we usually insert a Foley that has a 2- or 3-way Foley, and they give the patient continuous bladder irrigation. So there will be fluid consistently flowing in and then flowing out onto a Foley bag that the nurse will empty. In the beginning, the drainage will look quite bloody, and after some time will begin to clear up. One other thing to note for prostate procedures is that they use glycine instead of saline in this procedure most of the time because it's non-conducting. You are using cautery inside the patient, so you never would want to use anything flammable or anything that would cause injury to the patient. They can also perform this robotically. So if they are performing this robotically, same thing, patient would be placed into lithotomy and we would perform surgical scanning and asepsis. Patient would then be put in a steep Trendelenburg position. They will make an incision and place abdominal ports in the patient and insufflate the abdomen, which we talked a little bit about when I mentioned this for general surgery, for laparoscopic surgery. The robot is docked and the surgeon will move to the robotic console. They incise right over the patient, dissect everything out that they need to, free the prostate gland, and remove it through a port. They then hook everything back together, close all the port sites, apply dressings and skin glue. For postoperative care, that continuous bladder irrigation or CBI will remain in place until the urine drainage is almost clear, and that takes about a day. Patient might have a little scrotal support, which kind of looks like a little sling for their scrotum. They might utilize that, and that's just comfort for the patient. For 4 to 6 weeks, the patient should avoid heavy lifting and bearing down, as well as sitting upright for more than 1 hour. And they should refrain from sexual activity for 1 month after surgery. Complications for a prostatectomy can include clots, hemorrhage, TUR syndrome, which is a form of water intoxication in which the fluid is absorbed and produces systemic manifestations. They do use a lot of irrigation for these procedures, so it's very important to monitor the patient closely afterwards. It can also cause a urinary tract infection, micturition disorder, which is abnormalities in the process of urine voiding or the frequency of urination, and it can cause urge incontinence. Okay, well, here's some references you can check out if you want a little bit more information. I think I mentioned it a little bit, but if you are at the hospital, you can log into any computer to aornguidelines.org. It'll log you in automatically. We provide access through the hospital for all the nurses, but you can log in, and up at the top there's a few little tabs, and they have procedures at a glance. And you can click on any procedure that you've ever wanted to learn about, anything you wanted to know. They have wonderful diagrams, wonderful pictures. They kind of go through exactly what I just did. Why would the patient need this surgery? What are they doing in this surgery? They go through step by step everything that's happening. They have great pictures, great descriptions. They have a lot of other stuff on there, but the procedures at a glance Really helpful. So like I said, that's aornguidelines.org, and you can see those middle two references here. Utilize those guidelines, procedures at a glance. So yeah, you can look at anything. It's a great resource. If you haven't checked it out, you should do that, on a little bit of downtime at your clinicals. So I hope you learned a little bit about GYN surgery, and please don't hesitate to ask any questions if you have any.